So hi everyone, today we will be going through the OBGYN questions of the FMGE January session 2023. Right, so let's look at the first question. A primary gravida has given birth, it's a normal delivery. When should breastfeeding be started? So please remember that the WHO guidelines are that breastfeeding should be started within 1 hour, right? So that is the answer here. Remember, important contraindications for breastfeeding. So the single best answer is galactosemia. Okay, but the other important questions or contraindications that you should know is untreated active tuberculosis, right? So untreated active brucellosis, varicella zoster infection. Now please remember, when we say varicella zoster, it is the one which is acquired within 5 days before delivery, okay, to 2 days after delivery. Then what else? Apart from this, you have to know that the other important contraindications can be certain infections like HTLV 1 and 2. Then women who are on chemotherapy or radiotherapy, and if a woman has active lesions of HSV on the breast, right? So active HSV lesions on the breast. So these are important contraindications. Next is ventouse is contraindicated in. So when we talk about vacuum, the important or the most important contraindication specific to vacuum is actually prematurity, especially if the pregnancy is less than 34 weeks. The other important contraindications for vacuum especially would be breech, so baby in the breech presentation or baby in the face presentation. Certain other things would be contraindications for any kind of instrumental delivery, vacuum or forceps, which could be a woman who has contracted pelvis, right? A woman who has cephalopelvic disproportion, when the baby has certain bony deformities like osteogenesis imperfecta, or the baby has coagulation problems, could be because of anticoagulant drugs or otherwise, right? And conditions like if the membranes are intact. So we all have to remember that for instrumental delivery, the membranes should be ruptured. So intact membranes and unengaged head. So these are important contraindications that you should remember for instrumental delivery. Okay, so the next question is, which is not contraindication for normal vaginal delivery? So here the best answer is macrosomia. Why? Because you have to see the key word written. It says previous macrosomia. So the macrosomia is not present in the current pregnancy. It was in the previous pregnancy. So it is not a contraindication at all. Not absolute, not relative, right? Now when it comes to previous classical cesarean, it is an absolute contraindication for VBAC. Remember this. Similarly, unidentified scar, because this can definitely be a classical cesarean or a T-shaped scar. So absolute contraindication for VBAC. Now previous to LSCS is not an absolute contraindication. Yes, the chances of successful VBAC are less as compared to previous one, but you can do a vaginal delivery here as well. But previous macrosomia is a better answer here because macrosomia is not in the current pregnancy. Macrosomia in current pregnancy becomes a relative contraindication. Similarly, breech presentation in the current pregnancy becomes a relative contraindication. Previous LSCS with post-term pregnancy also becomes a relative contraindication. But here the macrosomia was in previous pregnancy. Apart from this, please remember history of rupture is an absolute contraindication. History of myomectomy, which has, where you have completely opened up the myometrium and reached the endometrial cavity, right? So myomectomy, where endometrial cavity is opened, is also a absolute contraindication. So you must remember these, okay? We'll move forward now. So a lady presents with frothy discharge, that is the first keyword, red vagina, sorry, and motility is seen on the microscopy. So you remember these keywords that I've taught you, greenish yellow discharge. If the MCQ says frothy discharge, yes, obviously this has to be a foul smelling discharge. The pH of vagina is going to be more than 4.5. On saline microscopy, you will see motile trichomonads. So that is the answer here. Then also you remember that in saline microscopy, the ratio of epithelial cells to polymorphonuclear cells, right, is going to be less than 1. Why? Because this is an inflammatory condition. In bacterial vaginosis, this ratio of epithelial cells to polymorphonuclear cells is more than 1 because there is no inflammation. In bacterial vaginosis, again, the pH is going to be more than 4.5, but it is a grey discharge, which is foul smelling. It can also be off-white discharge. And very importantly, when we talk about bacterial vaginosis in saline microscopy, what you see are clue cells, not motile organisms. This is not a STD, whereas trichomoniasis is a sexually transmitted disease. Let's look at the next question. Which type of placenta previa is shown here? So here the placenta is reaching the margin of internal os, right? Just the level of the internal os, and that is why this is going to be a marginal or a type 2 placenta previa. So if we look at the previous classification, marginal was also called as type 2, low lying was also called as type 1, partial was type 3, and central is type 4. Now in the latest classification, we do not have these terms. We only have two terms. Either we say low lying placenta or we say placenta previa. Low lying is if it is within 2 centimeters of internal os. Anything else, whether it is reaching the margin or central or partial, all of these are going to be put under only one term, which is placenta previa, right? Now, please remember, investigation of choice for abnormally located placenta is going to be transvaginal ultrasound. But don't get confused, the first investigation when a patient comes with antepartum hemorrhage is going to be trans-abdominal scan, okay? Now, remember, this is an important IBQ for your NEETPG as well. So, type 1 is far away from the internal os, within 2 centimeters. Type 2 is almost reaching. Type 3 is partially covering, type 4 is completely covering, right? So sometimes students get confused in the image of type 2 and type 3 when it is given like this. Please don't do it wrong. Postterm pregnancy is at and beyond 42 weeks. Between 41 to 41 plus 6 is what is called as late term. 39 to 40 plus 6 is what is called as term. And 37 to 38 plus 6 is what is called as early term. You all know that less than 37 is called as preterm. Now, although postterm is 42, but if they next time ask you when do you do induction of labor, if the woman has not gone into spontaneous labor, then we usually don't wait up till 42 weeks. We do induction of labor with 41 weeks. Yes, and please remember, carboprost, which is PGF2 alpha, is not used for induction of labor at term. You can use misoprost, you can use PGE2, right, which is cervi prime, but not PGF2 alpha, all right? Okay, so the next question is about obstetric audit. So obstetric audit is basically to keep a check on the outcome of the mother, of the baby. So definitely, do we keep a check on maternal deaths? Yes, so we keep check on maternal deaths. We also keep check on infant deaths. And we also keep check on conditions where the mother has severe morbidity, right, which is simply described as near misses, which means the woman was very close to deathbed, but you saved her eventually, right? Also, number of cesarean sections that are being done in a hospital, number of instrumental deliveries that are being done. So all these things which have an outcome on the maternal health are taken into obstetric audit, but as such, preterm labor is not a routine part of obstetric audit. So the answer here is preterm labor. Okay, best ultrasound parameter for gestational age assessment is crown rump length. Now this is the parameter which we see in the first trimester ultrasound. The ideal time to look for this is 7 to 10 weeks. Please remember that CRL can be used up to 14 weeks. Now beyond 14 weeks, the best parameter becomes biparietal diameter, which is the best parameter for fetal growth assessment. So whenever it is going to be about fetal growth, we will mark it as abdominal circumference, whether IUGR or macrosomia, right? So please remember, especially assessment of gestational age has been a repeated MCQ. So you must know these values, trimester in which it is the best time to do it. So that will be first. Okay, so what is the order of lochia in a postpartum woman? So it is rubra, serosa and alba. Rubra is what is discharged for first 3-4 days. It is red in color primarily because of bleeding or RBCs, but there will also be some decidua. From the 5th day onwards up till the 10th day postpartum, it is going to be serosa. So this is simply a pale colored discharge, which is because of reduction in the number of RBCs. And beyond the 10th day, it is going to be lochia alba. Now lochia alba can continue, so the total duration actually for which lochia can continue is anywhere between 4 to 6 weeks. Lochia alba is mainly made up of mucus and leukocytes. Now when we talk about, involution of the uterus also in the postpartum woman, you need to know that immediately after delivery, the uterus is at the level of the umbilicus, or we say corresponding to 20 weeks. Okay, and what will happen for first 24 hours, there is no change in the height of the uterus, but beyond 24 hours, it is going to go 1 finger breadth per day. So that is the rate of involution. So 1 finger breadth, or you can say almost approximately 1 centimeter, it will involute every day, right? Now, which means where would it lie on the second postpartum day? 1 finger breadth below, right? Remember, it becomes or comes midway between symphysis pubis and umbilicus by 1 week. And by 2 weeks, it becomes a pelvic organ, है ना? So it becomes a pelvic organ. If they ask you exactly at what time, so approximately 10 to 12 days postpartum, it becomes a pelvic organ. In weeks, we say it is 2 weeks. Okay, identify the conditions. So this is linea nigra. Now linea nigra, if we ask you, is mostly because of estrogen, which actually stimulates the melanocytes. So that is why you see pigmentation in the form of linea nigra, cloasma or melasma, and most of the times, whenever we talk about physiological changes of pregnancy, they are because of both hormones, E and P together. But when we have to mark one answer for almost all physiological changes, it will be progesterone, with some exceptions. So the exceptions where estrogen becomes the main answer are pigmentation, then spider nevi, they are also because of estrogen, then salt and water retention, increase in the levels of TBG, right, thyroid binding globulin, and obstetric cholestasis. So in these conditions, when you have to mark one hormone, the better answer actually is going to be estrogen. Okay, so this was a question which we have also covered in the TNDs and in the regular classes. So there is a woman, the age could not be recalled, but adnexal mass and also a mass in the uterus, or adnexal mass with hyperplasia in the uterus. So it's very likely to be a granulosa cell tumor. These are typically seen in perimenopausal women, and they are estrogen secreting. That is why they cause endometrial hyperplasia. Also, they can cause endometrial cancer. So granulosa cell tumor is actually a risk factor. And that is why we say that all women with granulosa cell tumor must undergo endometrial sampling. Although they are more commonly seen in perimenopausal women, granulosa cell tumors can also happen at any age. So they can also happen in younger women, or younger girls, I should say. So if they happen in younger girls, these girls are likely to present as precocious puberty. Remember, if you remember from the classes, we said precocious puberty can also be seen with germ cell tumors. And then, sometimes students would ask me, ma'am, so is germ cell a better answer for precocious puberty or granulosa cell? Then the answer is germ cell. Why? Because in this younger age group, the most common tumors are germ cell, they're not granulosa cell. Alright? Let's look at the next question. So a patient who's coming to us with dysmenorrhea and dyspareunia and bluish nodules in the pouch of Douglas. There was some doubt about probably nodules on the uterosacral ligaments, but it doesn't matter. Whether it is nodules on uterosacrals or nodularity in the pouch of Douglas, this is very characteristic to endometriosis. So whenever you talk about endometriosis, the most common symptom is actually dysmenorrhea. But they can also have chronic pelvic pain. They can also present to us with dyspareunia. And dyspareunia actually indicates that my patient has deep endometriosis. Alright, and when we talk about endometriosis, the other problems apart from pain that the patient can have are infertility and adnexal mass. So what is this adnexal mass? Yes, it is a chocolate cyst. So whenever you see a combination of these symptoms, you should know that the examiner is pointing towards endometriosis. What is the investigation of choice? Laparoscopy. So for endometriosis, the investigation of choice is lap, but it's not the first investigation because these women generally present to us with pain or adnexal mass. The first investigation that we will always do for them is an ultrasound or a transvaginal ultrasound, right? Chalo. Identify the type of pelvis. So when we talk about pelvis and you see that this one is almost circular inlet, then it is a gynecoid pelvis. And this is the Cadwell-Malloy classification, which is based on the shape of the inlet. So in the gynecoid pelvis, which is the most common type of pelvis, it is almost circular inlet. In android, it is heart-shaped. What is the inlet in anthropoid? It is antero-posteriorly oval, like this. So AP diameters will be much bigger than transverse. So whenever you have a doubt in the image, try and draw the AP in your mind and the transverse diameters. If the AP diameter is much more, then it is AP oval and it is likely to be anthropoid. This is where you see face to pubes delivery. This is the pelvis that you see direct OP or persistent OP. What is platypeloid? Platypeloid is just the reverse of this. It is actually a transversely oval pelvis. So transverse diameter is much more than the AP diameter. So transverse oval is platypeloid, which is where you see, face and brow presentations. Okay, so oxytocin is contraindicated in abnormal lie, like transverse lie. Why? Because when we talk about abnormal lie, vaginal delivery is not going to be done. And if vaginal delivery is not going to be done, we should not be giving oxytocin. Definitely you can give oxytocin in maternal exhaustion, right? You can give it in a woman with heart disease. You can also particularly, it's not contraindicated in women with hypothyroidism, so it is going to be abnormal lie, right? Remember important things, that do not give IV bolus of oxytocin. If you want to give it IV, it has to be infusion. So when you give IV bolus, and if they are large doses, it can cause severe hypotension. Not only that, this hypotension is quite severe enough to cause reflex tachycardia, in fact even reflex arrhythmias or a cardiac arrest. Okay, remember oxytocin has a very short half-life of 3 minutes. These are also important questions when it comes to oxytocin. Okay, so identify the type of forceps. So when we talk about this, this is the outlet forceps. How do we decide that? You always have to determine this with the lock and the length of the handle sometimes. So the lock in outlet forceps is English lock, which is what you see here. So what you see here is one blade is actually fitting into the other blade, right? So it's like a crisscross. So this is an English lock, and this is what we see in outlet or in release forceps. And especially when we talk about outlet forceps, they have short handle. Piper is a very long forceps. Okay, so it's a long forceps, so it has a long handle. Not just that, Piper is a forceps which has a reverse pelvic curve. So normally the outlet forceps, the Keyland, the Das, all of these have a pelvic curve, but Piper has a reverse pelvic curve, and Piper is what is used for the delivery of after coming head of breech. Keyland, how do you identify Keyland? So when you talk about the lock in Keyland, it's actually a sliding lock. So if this is the forceps, this would be the lock. So you can move the lock up and down, slide it along the handle. It has a sliding lock, not a crisscross lock. So Keyland is actually a rotational forceps, and it is again much bigger or longer than the outlet forceps. Okay, remember outlet forceps cannot be used for aftercoming head. So for aftercoming head, you will not be using release. The reason is that you can't use a short forceps here. You have to use a longer one. Okay. So what is the management of carcinoma cervix 1B? So when they say 1B, please remember the stage-wise treatment that I have done in the classes. So for 1A1, it is going to be type 1 hysterectomy, especially, when the family is complete. If the family is not complete, then we will do conization. Also remember, with type 1 hysterectomy, we will not do a pelvic lymphadenectomy. It's not included. With 1A2, we will do a type 2 hysterectomy, which is also called as AIIMS. And here we will do a pelvic lymphadenectomy. What if the family is not complete? So if the family is not complete, then for 1A2, we will be actually doing a procedure which is called as radical trachelectomy. Also, I'm going to give you a exception. If they say, there is stage 1A1 and there is LVSI. So LVSI stands for lymphovascular space invasion, and family is complete. Then we will be doing a type 2 hysterectomy. Okay. Whereas if it is with LVSI and family is not complete, then you will do a radical trachelectomy. This is a different answer for 1A1 when they give you about lymphovascular space. Now what about 1B? So remember, for 1B1 and for 1B2, for both of them, the answer remains as type 3 hysterectomy. Okay, so type 1B1, 1B2 is going to be Type 3 hysterectomy, again what we will be doing is with pelvic lymphadenectomy. What do you do for stage 1B3? Chemoradiation. So once it becomes bigger than 4 centimeters, you have to do chemoradiation as the primary treatment. Similarly, if there is parametrial invasion or if there is spread to lateral wall, then again it will be chemoradiation. Okay, so remember the stage-wise treatment for cancer cervix, it is important. LH surge is due to estradiol, and that too we have to remember high levels of estradiol, not low levels. So at least 200 picograms is what is required for a span of 48 hours. And when we say estradiol causes LH surge, please remember when it comes to maintenance of surge, it is done by E plus P both, right? And what is the time gap between LH surge and ovulation? 36 hours. What is the time gap between LH peak and ovulation? 12 hours. And once there is a LH surge, after that or after the mid-cycle, it is going to be the luteal phase because of the presence of corpus luteum. And the luteal phase is fixed to 14 days. Corpus luteum will have a lifespan of 14 days. Remember, it's the follicular phase which has different lengths in different women. Okay. Now, this lady is presenting to us with a blood pressure of 146/90 and she's 34 weeks pregnant. What should you do next? So, this is something that you should know we do in the antenatal OPDs for screening of pre-eclampsia. So, we take blood pressure of every patient, and if it turns out to be higher than 140/90, then you will also do a urine dipstick. If this is more than or equal to +2, then you label it as pre-eclampsia. Whereas if there is high blood pressure and no proteinuria, okay, as well as no end organ damage. So if no other complication is present, then it will be labeled as gestational hypertension. So now if I ask you, can you diagnose preeclampsia in the absence of proteinuria? Yes, which means if my patient has high blood pressure, but now she also has end organ damage, maybe not proteinuria, but she has end organ damage, then again this will be labeled as preeclampsia. So proteinuria is not a mandatory thing. Yes, and when you say end organ damage, remember the 5 points. So creatinine more than 1.1 is considered end organ damage. Platelet count less than 1 lakh is considered end organ damage. Presence of pulmonary edema. Liver enzymes more than twice the normal value. And lastly, any evidence of cerebral or visual symptoms. Cerebral symptoms like headache, dizziness, and visual symptoms like diplopia, blurring, and even blindness. So these are all considered as end organ damage. And even if my patient has any one of them, she will be labeled as preeclampsia. Okay? Chalo. Okay, this question we have already done. It is a repetition. And this also I have already covered for you. So absolute contraindication for breastfeeding. As I said, whenever there is an option with galactosemia, that is the best answer. HIV, please remember, is not a contraindication. In fact, in developing countries and our national guidelines, NACO says breastfeeding is recommended. And in that they say 6 months के लिए it should be exclusive breastfeeding. ठीक है? And it should ideally or preferably continue up to 2 years as well. Hepatitis B, CMV, these are not contraindications for breastfeeding. Okay, so you can go back to the question where I have discussed contraindications and you have the other important ones written there. Okay, So a lady is coming to you in the second trimester. She has a 2-year-old child. So what are you going to give her? You're going to give her a TD booster. So please remember, if the pregnancy is within 3 years of antecedent pregnancy, so if the new pregnancy is within 3 years of antecedent pregnancy where the woman was fully vaccinated, which means she has received 2 doses of TD. So if she is fully vaccinated, then she will only receive the booster. And if it is beyond 3 years, then yes, you will give her TD1 and then TD2. This is given at the first antenatal visit, and there should be at least a gap of 4 weeks before she receives the second dose. Okay. Alright, something that we have very routinely discussed. So if the zygote division occurs between 9 to 12, what would be formed? So remember, first 3 days it is dichorionic diamniotic, 4 to 8 monochorionic diamniotic, 9 to 12 or beyond 8 it is monochorionic monoamniotic. So that is the answer here. And beyond 12 days it is going to be Siamese or conjoined twins. Now please remember, these are types of what? Monozygotic twins, right? And among this, which is the most common monozygotic twin? So most common monozygotic twin is actually MCDA. But if the word monozygotic is not there, then the answer changes. If they simply ask you most common type of twin, then you have to know that these are dizygotic. So the ratio is 70 dizygotic, 30% monozygotic. So most common type of twin are dizygotic, or simply the answer will change to DCDA. So don't get confused with this. Remember, an important marker of dichorionicity is lambda sign, also called as twin peak sign. Again, ideally seen in the first trimester between 10 to 14 weeks. This again we have discussed. In fact, we have discussed the involution of the uterus as well. So because at umbilicus or 20 weeks is not in the options in this question, we will go with below umbilicus, right? And also remember, if you see sub-involution in your patient, then this is a marker of endometritis. You should be starting her with antibiotics. She may even present with fever. There will be uterine tenderness, and sometimes there may also be a foul smelling discharge, right? So these would be markers of subinvolution and a resultant endometritis. Okay. A lady presents with history of lower abdominal pain and restricted movements. A lap is done and you're seeing trickling of pus from the fimbrial ends, a very characteristic feature of pelvic inflammatory disease. Now when you talk about PID, please remember it is a disease of upper genital tract. So it includes uterus, fallopian tubes and ovaries. It doesn't include cervix and vagina. They are lower genital tract. Also remember, the highest risk factor is with multiple sexual partners, and PID is most common in younger girls. So in the second decade. Also remember, in the lab, what else can you see? Perihepatitis, which is violent string adhesions in 10% of these girls, and this is what is called as Fitzhugh syndrome. And when we talk about lap, you have to know that there is a scoring system for PID prognosis on laparoscopy, and this scoring system is called as Boyer-Meisel scoring system. Okay, and this scoring system tells us that what are the chances that the woman can get pregnant after a event of PID. Now, Boyer-Meisel system includes a lot of things that we see in the woman's fallopian tubes, but what we don't consider is what organism has caused this damage. What we consider for prognosis is how much is the damage. So, you will look at the size of the hydrosalpinx, the condition of the hydrosalpinx, the number and type of adhesions your patient has, but you are not going to take into account in this prognosis the organism which has caused it. Okay, PIPL. What do we use the PIPL for? Again, directly from your class notes. So PIPL is basically used for endometrial sampling. Yes, it is an OPD method, and in India usually we don't use PIPL. What we use is Carman's cannula. And yet another device that can be used for endometrial sampling apart from these two are Vabra aspirator. Remember, if a lady comes to you with post-menopausal bleeding and the endometrial thickness is more than 4 mm, you must do an OPD method of endometrial sampling. Classically, what we used to do was endometrial biopsy. So you see that in a lot of places as options. But these days, instead of the endometrial biopsy, we are using a PIPL or a Carman's cannula to take the endometrial sample. Okay. Right. So again, directly from the class notes. So this is a procedure of lap ovarian drilling, which we do in PCOS. It is a second line treatment for infertility in PCOS women. And what do we do here? We actually reduce the stroma. So in PCOS, there is stromal hyperplasia, and because the stroma is what is containing the theca cells, there is theca cell hyperplasia, and the theca cells are the ones which are producing androgens. So when you burn the stroma, you reduce the theca cells, you reduce the androgen production. Yes? Okay. Fracture of the clavicle is called as cleidotomy. It is done for shoulder dystocia. Craniotomy, remember, as well as symphysiotomy, they can be done for obstructed labor. But you all know that destructive procedures are no longer done in modern obstetrics. Yes, so rather we would be preferring to do a cesarean section when a woman has obstructed labor and dead baby. So if she is in obstructed labor and she has a dead fetus, we will not be doing a craniotomy or a symphysiotomy. We would be doing a cesarean section. Okay. So copper T380A has a half-life of or lifespan of 10 years. It's actually the lifespan. 5 years is for copper T375. For Mirena, it is now actually 7 years. Remember, the main mechanism of action of whatever IUD it is, copper or Mirena, is inhibition of fertilization. If that's not in the option, you can go with inhibition of implantation. But you have to know that intrauterine device do not act by inhibition of ovulation. Even with Mirena, most cycles are ovulatory cycles. Okay. So they had given a diagram like this. They had given number of the position, and they had asked what is the most common site of ectopic pregnancy. So, you had to mark the number which corresponds to the ampulla, which is actually the widest portion of the fallopian tube, and it is the most common site for fertilization as well as ectopic pregnancy. So it is the ampulla. And please remember, the most common outcome of ampullary ectopic is tubal abortion. It's not rupture. Okay, it is tubal abortion. The most common outcome of isthmic ectopic is rupture uterus, right? But which rupture ectopic is most dangerous? Intramural. Because it is going to be life-threatening, because the uterus is also going to rupture. Remember, the intramural part is also called as interstitial, and it is the narrowest part of the fallopian tube. It's not isthmus. Isthmus is narrow but not narrowest. Labetalol. So a pharmacology question, but we've covered it routinely, is alpha plus beta blocker. It is the drug of choice for hypertension in pregnancy. It should not be given to asthmatics, right? And it is also the drug of choice for acute hypertension. The difference is, if it is acute hypertension, you will give it IV. Otherwise, you simply give it as oral labetalol. Now, rate of cervical dilatation in the active phase of labor is 1 centimeter per hour. That is, what is minimum requirement to say it is normal progress. But if they ask very specifically, then you have to know that in primigravidas it is 1.2 centimeter per hour, and in multigravidas it is 1.5 centimeter per hour. Yes, and please remember, as per the ACOG guidelines, the active phase now begins at more than or equal to 6 centimeters. But when we talk about WHO routine partograph, okay, which was the modified partograph, here it is more than or equal to 4 centimeters, and with the WHO new labor guide partograph, they say now we will consider in the labor guide partograph as beyond or equal to 5 centimeters. So just pay attention to the keywords and then answer. Okay, if nothing is mentioned, then as I said, for clinical practice, we're currently using active phase as more than or equal to 6 centimeters. Okay, best management to prevent recurrence of endometriotic cyst is cystectomy. Cyst aspiration and cyst ablation are not to be done. They have a very high recurrence risk of more than actually 70%. Also remember that endometriotic cyst does not respond to medical management. So it won't resolve with either progesterones or OC pills. It doesn't respond to medical management. So if the cyst is bigger than 5 centimeters or if it is symptomatic, then you have to do a surgery, which is cystectomy. If it is less than 5 centimeters and it is asymptomatic, then yes, you can simply do a wait and watch, and you can follow up with serial ultrasounds to see what is happening to the size of the cyst, or in case it is undergoing certain complications or pain. Okay, a very basic question. Testosterone is secreted from the Leydig cells. Certainly cells will secrete MIS. Yes. Now testosterone, remember, converts into dihydrotestosterone in the periphery, not in the testes. And this enzyme is 5-alpha reductase. Okay, the karyotype would be 46XY, but the external genitalia can be female-like. They can also be ambiguous, right? But they can be female-like. So this produces a male pseudo hermaphrodite. Okay, most common indirect cause of maternal mortality is anemia. So indirect क्या होता है? If it is because of worsening of a pre-existing disease. Okay, hemorrhage, pregnancy-induced hypertension, these are things which are happening specifically in pregnancy, right? So disorders that are specific to pregnancy would be called as direct cause of maternal mortality. Anemia, heart disease, they will be called as indirect cause of maternal mortality, and the leading one definitely is anemia. Okay, dysmenorrhea with tender uterus is with tender uterus is adenomyosis, right? So adenomyosis, not only it's a tender uterus, it is enlarged to 10 to 12 week size, it is soft, it is globular, and the cut section will show hemorrhage in myometrium. The first investigation, again, because it is coming to us with dysmenorrhea or enlarged uterus, would be a TVS, right? Whereas investigation of choice for adenomyosis is going to be what? MRI. You must remember the classic signs that we see on TVS, especially when we talk about it: the Venetian blind appearance, the myometrial cyst appearance. Also remember the name which is called as salt pepper myometrium. This is again something that you see with adenomyosis. And then poorly defined junctional zone. So these are special findings on ultrasound itself. So poorly defined which junctional zone? Junction of myometrium and endometrium. And in MRI, what do you see? You actually see a thickened junctional zone. So we say if it is more than 12 mm, it is suggestive of adenomyosis. Whereas if it is less than 8 mm, it rules out adenomyosis. Right? So those were the questions. So we have a good chunk of questions of obs and gynae in both FMGE and NEETPG exams. It's an important subject, but it's a very scoring subject. I want these previous year questions to be crisp discussions. We shouldn't be spending hours and hours, because then it is like revising the entire topic again. Your idea with PYQs should be that we should not do this particular question wrong if it is asked as it is, and these topics I should be revising from the notes. These videos need to be small so that you can watch them multiple times, even close to the exams, make it more useful for you for rapid revision. Okay, take care everyone. Bye-bye.